Okay, so let's get started. So as we can see, the topic of my talk is why integrative medicine philosophy of traditional healing systems can save the US healthcare system. So it's a fairly tall order, given the state of affairs, which I'm going to be talking about. But I hope by the end of this talk that I can convince you that this is a plausible argument. So firstly, let me introduce myself. My name is Belinda Anderson, also known as Bo Anderson. I came to Monmouth University a little over a year ago to take up the position as director of the Institute for Health and Wellness. Prior to that, I had been in New York City working at Albert Einstein College of Medicine and Pacific College of Health Studies, doing academic administration, research and teaching. I have a research background in clinical trials looking at integrative medicine effectiveness, particularly with the underserved. And also before that, I was actually a molecular biologist, so I did a fairly significant career change. I am a licensed acupuncturist and spent 10 years working at NYU Fertility Center, where obviously I specialized in gynecology and obstetrics, especially fertility. And of course, most of my patients were trying to conceive. So what I'm going to be talking about today, it connects directly to acupuncture, acupuncture being one of the integrative health techniques. But I really want to bring it out and talk more broadly about integrative medicine. If you're unfamiliar with that term, don't worry, I'm going to go quite carefully through what that term means and what the whole integrative medical movement is in the context of American healthcare, using the Veterans Administration, the largest healthcare system in the world, as an example of the way in which integrative medicine can be implemented, because that's actually what's happening in the VA, and I'll talk a little bit about that. So let's get started. So I am going to be talking firstly about the status of the US healthcare system. This may be familiar to many of you, but I think it's very important to put it in context before we think about how we would possibly provide solutions for some of these issues. So we'll be talking about cost, quality issues, the opioid crisis, which I think really underscores a lot of the cost and quality issues, and about the payment system, because ultimately the way in which healthcare is paid for determines the incentives for large healthcare center providers. So then I want to move on to integrative medicine and health. What is it? What are the practices that constitute that? What about the research and evidence for its effectiveness? And then lastly, I want to talk about implementation, which is really the phase that we're at now in this country, and that being so important for the impact that it could have on our current US healthcare system. So I think this cartoon kind of nicely illustrates what we've seen happen to the healthcare system in the US over the last 100 years. So we went from the house call being a relatively common feature of the interaction between a family practice physician and a patient. We then moved into more of a defined infrastructure, so patients more usually went to a healthcare facility. Then things got more complicated, and we've probably all had personal experiences with the way in which the insurance system has changed, particularly over the last decade. And the issues that we can see illustrated here, where often you cannot not even have a procedure before you've got clearance from the insurance company. And if it's a certain type of procedure, you may not even have coverage for that. And then worse still, as insurance has become more complicated, in part because of the Affordable Care Act, and I'll talk more about that, but now we're seeing an even more complex situation where employers are constantly switching insurance companies to get better deals because of the enormous increases in costs that we see happening year over year, and the impact that that has on the consumers, the patients, who have to constantly be changing providers because they're not in the insurance network of the new insurance company. So we've really reached a situation now with it's kind of at a crisis level because of the lack of continuity of care. So every time you change your healthcare provider, the records of your previous care don't automatically transfer with you. And so there's the continuity of care. Many people don't get care or get the wrong type of care because of that. And also the out-of-pocket costs, as we all know, have increased very significantly. And we're going to talk about the impacts of that. So the healthcare is the number one election issue, and the word crisis is not alarmist or extremist. It's used commonly to describe the US healthcare system as we now see it. So cost is a huge issue. And what I want to demonstrate here is the comparison of the cost of healthcare in the US to other developed nations. And this only goes up to 2015, and we can see that at that point it was bumping up somewhere a little over 17% of the GDP. Now fast forward 4 years later, and it's almost 20% of the GDP. So that's bad enough, but it is really underscored when we compare it to other developed nations. So it is typically double the expenditure that other countries are making on healthcare. So what would we expect for that? We would expect that the quality would be better. But I'll show you some data that shows that the quality is not better. So here, just another illustration of how much we spend per head of population, running a little over 9,000 annually, and compare that to other countries that are spending like half, but in some cases, a country like Italy would spend a third of that. So as I mentioned, so we would expect that America would have the best healthcare system in the world if we're spending all this extra money. But that is very, very far from the truth. Just for something like childhood mortality, we're running sort of something like 37th in the world. So here, this looks at overall healthcare ranking. And you can see the US right down the bottom, below many of these other developed nations. We have the UK and Switzerland right up the top, and we have a bunch that are kind of more in the middle, and then right down the bottom is the US. So if this was our military system, we would not be just sort of saying, oh, well, if we were spending more than any other country in the world and yet had a military system that gave us less protection and left us vulnerable, we would not be shrugging our shoulders and saying, oh, well. So combine this with, obviously, we're going to be concerned about the issue of high-cost, subpar quality, but it goes a little bit further than that. So people are obviously concerned about those issues, but they're also concerned about the issues that I talked about, the personal impact. And so it's estimated now that about 70% of Americans believe that the country's health care system has major problems. So let's dig a little deeper into that. So a recent study that was a combination of qualitative interviews with consumers and also health industry experts, along with a survey of a little over about 3,500 randomly selected adults, outlines what the key issues are for the American public. So Americans overall expressed a great deal of concern about healthcare costs. 45% were concerned that a major health incident for them personally could lead to bankruptcy. You probably all know of somebody who's had that experience. 77% were concerned about significant and lasting damage to the US economy, particularly if this trajectory of rising costs continues. It's basically unsustainable, and that, nobody is arguing about that issue. So there's a real lack of transparency in the nature of healthcare costs. So 47% of people went to the ER but didn't know how much that was going to cost them before they had already received the care and then ultimately would get the bill. And 41% felt like they needed to go to the ER in the last 12 months but didn't, because they had heard about other people who did, who got these enormous bills unknowingly. And generally speaking, many Americans can't afford to make health a priority. So Americans borrowed $88 billion. This is within the last 12 months that this survey was conducted in 2019. $88 billion to pay for their health care, and 65 million adults didn't seek treatment because they could not afford it. So is this really what we would expect for a country like the US, who spends, at least double on healthcare than any other country in the world? So the opioid crisis is kind of like the final straw, really. And it sort of underscores a lot of what the drivers are of this overall situation. So firstly, the opioid crisis is about the incidence of pain in America. So about 1 million Americans are burdened by chronic pain, and this costs us around 560 to 635 billion annually. Now, to put that into some type of context, that is more than the combined cost of treating the 3 biggest killers in this country, which are diabetes, heart disease, and cancer. So the scale of pain is sort of kind of mind-boggling. And the unfortunate thing is, as the population ages, as we head towards 2030, 20% of our population will be 65 or older. And this is also a global trend. But pain increases with aging. So this situation, this cost, is only going to increase over time. So this just shows diagrammatically the people that are suffering from chronic pain in comparison to those other diseases that I mentioned, cancer, heart disease, and diabetes. So it's estimated that more than 30% of Americans are living with some form of chronic or severe pain. So that's a lot. That's almost 1 in 3. So, of course, unsurprisingly, we have ended up with a crisis in terms of medications that have been commonly used to treat pain. So we've had a dramatic increase in overdose death related to opioids, and currently about 130 Americans die every day because of an opioid-related overdose. And this has had, sort of interestingly, a high impact on unemployed and disabled workers in economically devastated industrial communities. And it has disproportionately affected middle-class white people in non-urban areas, so in rural areas. And it's estimated that between 2007 and 2014, the dependence on opioids rose by over 3,000%. These are privately insured patients in these types of communities. So this is not a problem that we would associate with the underserved necessarily. So this just shows graphically how the death rate from opioids has increased dramatically exponentially from about 2010 up until our current situation. And despite enormous spending on this problem, it is not getting better, it's actually still getting worse. So the National Institute of Health, that I'll talk more about, just gave out $950 million just in this past year for research on trying to make some progress towards this problem. So this is an American issue, where 4.6% of the world's population, but we consume 80% of the opioid medications. And if we just took one alone, hydrocodone, we actually consume 99% of that drug. The US prescribes 50 times more opioids than the rest of the world combined. So something's going on here with Big Pharma, and unnecessary procedures, lack of focus on looking at other approaches to this problem. But the saddest thing of all is that even with all of these high levels of consumption of these medications, 70% of patients still complain of moderate to severe pain that are taking these medications post-operatively. And we now know clearly from the evidence that opioids do not manage chronic pain. Acute pain, yes, after you've actually had surgery and you're still in that very acute phase, they help. But if it's a chronic pain situation, it's not an effective form of treatment. And instead, people end up getting addicted, and then in a lot of cases, they don't deliberately overdose, they accidentally overdose. They accidentally take too much, or they combine it with another drug that also has an opioid component to it, and they then, it slows down the respiratory rate, the breathing, and then the person sort of, accidentally dies. That's the tragic thing about it. So let's move away from that and talk about what some of the financial drivers are for this sort of overall situation. So let's look at the US healthcare payment system. So we all are becoming increasingly aware that our healthcare system is really motivated by profit. So, to put it less glamorously, this is profiting off other people's suffering. So when we break health insurance down, about 17% of the insured US population is on Medicaid. And we know that Medicaid is for people in the lower socioeconomic demographics, and I've given you the actual numbers there for who would qualify to get Medicaid. So Medicare, seniors over 65, people that have also paid their taxes for more than 10 years, is about 18% of the insured US population. And then 66% have private insurance, and I've given you some estimates of the cost, which is very, very high. And of course, it's not just the monthly cost, but it's also the amount that you are responsible for once you start using your insurance coverage, the deductible, which is also very high. So about 91% of the population has insurance, which of course that increased after the Affordable Care Act. But there is over-discrimination against people who are on Medicaid and Medicare. So some healthcare providers can turn away a patient whose insurance is Medicare or Medicaid because the level of reimbursement is lower than those that have private insurance. Some can't, so some are mandated that they must take those patients, but many do. It's discretionary for others. So there's also kind of like a hierarchical system within people that have health insurance. So there are basically two forms of the way in which insurance works. There's fee-for-service and there's value-based reimbursement. So fee-for-service is where the payment is based on the services that are actually delivered. So every time a patient goes and gets a blood test or has a procedure or surgery, then there's a cost associated with that. The provider reaches out to the insurance company and gets reimbursed for the cost of that procedure. So this is, an example of one of the perverse incentives. So the more interventions that are undertaken, the increased levels of profit for the healthcare providers. And so it's estimated in this country that about 40% of medical procedures are unnecessary. But what they do is drive profit levels for the healthcare providers. So about 70% of reimbursement is based on fee-for-service. So value-based reimbursement, this is one of the real value pieces of the Affordable Care Act. So the Affordable Care Act required or is gradually requiring federal sources of health insurance to be based on value-based reimbursement. So Medicaid, Medicare, and now we're even finding that some private insurance companies are using the same model. The reason why it's good is it lowers costs, but it does it because reimbursement is based on the quality of the healthcare that is delivered. So what has been happening since the Affordable Care Act started is that all these metrics have been developed that measure quality of healthcare services delivered. So things like hospital readmission rates. So now if it's a value-based reimbursement system, when the patient gets released from the hospital after their procedure, they need to be tracked and followed. So that often there's an assumption like, oh, they'll go back to the primary care provider and they'll make sure that they're okay following the surgery. But because of this discontinuity with healthcare records, that doesn't necessarily happen, and even more so with an underserved patient population. So often those patients will wind up back in hospital because they didn't get the proper care while they were recovering from their surgery. So these are the types of metrics. Another good one is patient satisfaction. So this is a very different incentive model where the increase in quality leads to greater profits. So an accountable care organisation, which is under a value-based reimbursement system, actually will receive a kind of like a rebate or a refund at the end of the year if they have met those quality metrics, and the better they have performed, the more money they get back. So this is aimed to improve quality and lower costs, and as I mentioned, we are seeing some private insurers moving towards this, but depending on what happens with the outcome of the next election, if we are to get either a single payer or a public option, this will also help to further drive value-based because the federal government will be more involved with health insurance and they will require a value-based reimbursement system. The other thing that's really valuable about the value-based reimbursement is that there is finally an incentive for healthcare entities to help to prevent illness and keep the health of the population at a better level. And this is especially so in capitation and bundle payment models. So what we mean by those is these are models whereby a healthcare centre will be given X amount of dollars for each person that they take care of. So a federally qualified healthcare centre, for example, those are mandated to provide healthcare services for anybody that walks in the door. So that's the underserved, that's undocumented immigrants, uninsured people. So these are based on a capitation system. So they get X amount of dollars for every person that's in their healthcare system, but they can spend that however they like. Another example is cancer care. So they often work under what we call a bundle payment model, where they reimburse X amount per patient that they're caring for, but they can spend that however they want to. So we see in cancer care an enormous uptake of integrated therapies. And in the federally qualified healthcare system, what we see is a lot more focus on prevention and wellness. So things like education about how to stay healthy, how to eat a better diet, where to shop, some of them provide food. We're even seeing some healthcare systems now provide housing to people, realizing that that can actually help them to stay well. So this is also enormously beneficial for us to have an incentive to improve the health of the US population. So the last thing I want to mention about the current status is that there is now a very large amount of research evidence demonstrating the effectiveness of integrative medicine. And so this combined with value-based reimbursement and increased consumer dissatisfaction with other options is really helping to provide a sort of turning point in US healthcare. So now that I think I've provided you with a very convincing argument that A, we've got a problem, and B, we have alternatives that have a great research basis and also a payment system, a fledgling payment system, let's look more deeply at what this solution is. So integrative medicine and health is what we would have called, I think this name went out of favor at least 5 years ago, but even more so in different communities. So we no longer talk about alternative medicine. The NIH changed the name of their complementary and integrative healthcare unit, I think 3 or 4 years ago. So other names that you'll hear for integrative medicine and health is complementary integrative health, traditional and complementary medicine, integrated medicine, integrated healthcare. They basically all mean the same thing. So this is a definition that I like to use. This is from the Academic Consortium for Integrative Medicine and Health. Academic Consortium consists of almost every medical school in the country now, and all of them are buying into this form of healthcare and including it in the curriculum for MD training programs. So integrative medicine in health reaffirms the importance of the relationship between the practitioner and the patient, focuses on the whole person, is informed by evidence, and makes use of all appropriate therapeutic and lifestyle approaches, healthcare professionals, and disciplines to achieve optimum health and healing. So another version on this thing from Duke University of Integrative Medicine. Integrative medicine is an approach to care that puts the patient at the centre. So you've probably heard a lot about patient-centred care, the patient-centred medical home. It's the same concept. Addresses the full range of physical, emotional, mental, social, spiritual, and environmental influences. It employs a personalised strategy, and it treats each patient as a unique individual. And it looks at their unique needs and circumstances, and then it uses appropriate interventions based on scientific research to demonstrate their effectiveness, and it's ultimately aimed at attaining or maintaining optimum health. So I want to break this down a little bit and discuss some of these individually. So in this model, the patient and the practitioner are partners in the healing process. So we want to try and break down the hierarchy of the doctor being this person who you never question, who knows everything, who is going to give you 100% accurate information that you should follow to the letter every time you see them. We all know that that is putting way too much responsibility in the hands of one person, and the doctors don't want to be treated like that. 60% of physicians show signs of burnout, and part of it is the stress of this level of responsibility. So when you partner, you also share that responsibility. So we're trying to encourage patients to take more of a personal level of responsibility for their own health, the healthcare problems they have, and also preventing healthcare problems from starting in the first place. So it takes into consideration all the factors that influence health, wellness, and disease. And so this is where we get the whole person, or the body, mind, and spirit. So we're thankfully moving away from this concept that ill health is a physical thing. It's really obvious that many illnesses, and especially now more so than ever before in human history, we are seeing illnesses related especially to psycho-emotional conditions, and especially in the youth. So as we see increasing levels of anxiety, depression, and suicide amongst our youth, we really need to broaden our scope in terms of the etiology of healthcare problems. So providers use all healing sciences to facilitate the body's innate healing response. So there's a couple of important things there. So we need to move away from only considering conventional approaches, and particularly if we're thinking about prevention and wellness. But we also need to have a lot more respect for our own bodies and our own innate capacity to heal. One of the problems with both healthcare and healthcare research is we always just look at one point in time. So you go in, you have a health problem, they run a whole lot of tests on you, but they're only looking at that particular moment in time. And then you have some type of intervention, and we never, or very rarely, have the opportunity to see what would have happened if that intervention did not occur. And in the less common instances where we do track what happens to a healthcare problem, the rates of natural resolution, or the body being able to overcome a healthcare problem, are not to be underestimated. And there's also ways in which we can facilitate that. We know that just from ourselves. If we're not feeling well, something as simple as getting to bed a little bit earlier, or changing our diet, or doing a little bit of exercise can really help to make a difference in how we feel every day. So there's a focus on interventions that are natural and less invasive, and those are to be used whenever possible instead of something that has a greater potential for side effects or a long-term recovery. So we want to avoid people having to take medications. Most medications have side effects. They interact with each other. You want to think more carefully, does that person really need to go on that? Surgery, once you start cutting in, you have scar tissue, you have a lot of other things that can happen as a result of that. So good medicine is based on good science. So we need to obviously look at the evidence, the scientific evidence, but we also need to be open to new paradigms. So science and medicine are continually evolving disciplines. And the things that we thought were best practice 10 years ago, 50% of those have been disproven. One of the problems is that often those old, outdated, disproven approaches to healthcare don't get replaced by the better approach that's been proven through research. So we want to really focus on the promotion and prevention of illness. And this is something we generally see people once they get sick. We don't have good ways of helping people to better understand how to prevent getting sick. Care is personalized. Everybody is a unique individual. What works for one person doesn't necessarily work for another person. And that is obviously because of their physical body and their genetic code and things that are more obvious, but also it's to do with their needs and circumstances, these so-called social determinants of health. And lastly, the practitioners have to walk the talk. So if we're asking our patients to engage in activities which helps keep them well, we have to mirror the same behavior, and we also have to be able to talk with our patients openly and honestly about our own failings to always get it right. And that can, in my own experience, have a dramatic impact on really connecting with the patient and helping them to be more motivated to try again. I mean, we're always going to fail, particularly with behavioral change. It's very hard to change those old habits that we've somehow become really attached to. So integrative health and medicine incorporates all of these very important aspects of healthcare. The biopsychosocial model, which would be familiar to all of you folks, the social determinants of health, which we now understand contribute approximately 80% to someone's health status. So healthcare is about 20% of somebody's health status. The social determinants, which I'll talk about, 80%. Evidence-based medicine. All medicine and healthcare should be based on evidence, and it's really a process of critical thinking. And lastly, into professional education. We need to dissolve those silos. We need to start working together where there's a lot of overlap between different healthcare professions, and we can do a much better job of working together for a better outcome for patients. So biopsychosocial model, one that I'm sure you're all very familiar. This was where we moved away from just thinking about ill health as a physical thing and recognize the importance of the psycho-emotional aspect and also the social aspects. Our level of education, the community that we live in, relationships, and also our socioeconomic status. So social determinants of health, it's been a real spotlight placed on this now, in part because for the underserved, paying attention to these is recognized as a real significant way to reduce costs of providing healthcare for these folks. So if we pay more attention to the fact that many underserved people don't have the education to know how to take better care of their health, to, for example, know what a healthy diet would be like, or they live in a geographical location, which is a food desert. You know, they might be buying a lot of their food from the local gas station, or they might live in what we call a food swamp, where the only available food is fast food, McDonald's, and that sort of thing. They might have unstable housing. They might have unstable employment. They might be moving from one job to the next. They don't have control over their work schedule. They might not be able to take time off to go and do things to be able to take care of their health. And lastly, comorbidity. Often the underserved have a lot of healthcare problems and then they negatively interact upon each other. So just from the little bit we've discussed, you can see there's a huge scope to have an impact on these factors, and considering that they're 80% of the health presentation, that should really be able to reduce costs and improve health. So evidence-based medicine. So evidence-based medicine, we think, simply means applying scientific evidence to the practice of medicine or healthcare. In other words, I read it in the journal, and I say, oh, that's how you meant to treat fill in the blank, and then the next day I go into my clinic and I do exactly that. So that's totally unrealistic. How many healthcare providers are actually reading the evidence? It's a very low percentage. We do require healthcare providers to do continuing education, but that doesn't necessarily mean that they've been exposed to the research. What we do hope is that there are enough evidence summaries which provide clinicians the ability to quickly catch up on research, and also conferences and places where they do their continuing education have a research focus to help people stay up to date. But one of the other really important aspects of evidence-based medicine is that it's not just applying research evidence to practice. It's a combination of three things. It's also inclusive of patient values and preferences. So you can have the best intervention, the most effective intervention according to the research for a patient, but if a patient doesn't want to do that, they don't want to take the drugs or have the surgery or take the Chinese herbs or do the massage therapy or whatever it is, then that is not an appropriate approach for them, and you need to rethink and come up with a different suggestion. So clinical experience. So even though the research might suggest one thing, you're an experienced clinician, you've been treating patients for many decades, and you know that this particular treatment for this individual person is going to be the right one for them. So we must honour the experience of our clinicians who are working at the coalface and put that as equally as important as the actual scientific research itself. So lastly, interprofessional education. As I mentioned, we hope that all of our healthcare providers work together, that we share our expertise. The biggest challenge for interprofessional education is the cost of having multiple clinicians working on a single patient case. And the fundamental question is who's going to pay for that. So in our healthcare reimbursement system, we're paid frequently with a fee for service according to the interventions that patients receive. So providing funding for clinicians to actually discuss individual patients is going to continue to be a challenge within the healthcare system. Except, in things like bundled payment or capitation models, where it's not based on the number of interventions, the healthcare facility can decide how they want to treat an individual patient. So what are the disciplines and the types of practitioners and the therapies that belong in this broader field of integrative health medicine? Well, the first category I want to mention are the 5 licensed complementary integrative health professions. And so in all of those, what we used to call alternative medical approaches, there are only 5 that actually have education and licensing infrastructure. So it's chiropractic, acupuncture, massage therapy, naturopathy, and midwifery. MDs are increasingly practicing integrative health medicine, and we call them integrative physicians, and also functional medicine doctors. Functional, what's the difference? So functional medical doctors tend to focus more on supplements, so they're a bit similar to a naturopath, whereas integrative physician will make a lot of referrals to the licensed complementary integrative healthcare professionals, and will also pay a lot of attention to social determinants of health and other ways like education that they can help their patients. So a lot of these MDs are family medicine docs doing primary care. And of course the nurses, they are the nurses are the workforce of the healthcare industry. And there is a new movement in nursing now called holistic nursing. And many nurses who have been trained as holistic nurses will do a variety of different interventions. Obviously not the licensed interventions, because you have to have a license to be able to do those, and it's illegal to do it if you don't have a license. But they will do things like aromatherapy, touch therapy, meditation, and those sorts of things. And this is increasingly happening inside hospitals and clinics. So what are some of the therapies besides just looking at the practitioners and disciplines? So Supplements, as we all know, we are increasingly seeing supplements in anywhere from Whole Foods to our local supermarket. It is now a $60 billion industry, and of course that includes a variety of different types of substances, probiotics, herbs, tinctures, and individual amino acids and vitamins and minerals, and it's pretty extensive now. One of the challenges with natural products is that they're largely unregulated. So there's no FDA participation in the supplement industry. And of course, people have free access, they can just buy them over the counter. And we're increasingly finding that there are some very significant health dangers associated with supplements. Supplements by themselves, but supplements mixed with other supplements, and supplements mixed with pharmaceutical drugs. And we really do need to do a lot more activity in that arena to make this safer. So movement therapies, so we're seeing a massive increase in yoga. Places to do yoga are cropping up all over, from healthcare centres to hospitals to local suburban shopping centres. Tai Chi and Qigong are increasingly preferred. One of the reasons that they are preferred is because they are a more gentle form of movement. Yoga is great. You can actually get hurt doing yoga. It's much less common to get hurt doing Tai Chi and Qigong. Meditation. Mindfulness-based stress reduction is a great example of the form of meditation that's become very popular. Health coaching. So the American Medical Association just approved a CPT code for health and wellness coaching, and that will come into effect as of January next year. So I think we're going to see a real expansion of health coaching. And in relation to the social determinants of health that I discussed before, this is really going to be a mechanism to help people with the education piece and the motivation piece. So health coaches can introduce new wellness practices for people and describe them, give them advice on where to find the products or the classes, but even more importantly, they can meet regularly with those people and really encourage them to stay with the program and make those long-term changes. Nutrition and special diets are obviously an important aspect of this. And lastly, I just want to mention, because you're probably thinking there are a bunch of other things, and they're kind of what I would call the emerging therapies. We differentiate those from the licensed complementary and integrated health professions because they don't have an established infrastructure for education and licensing. So things like Reiki, reflexology, homeopathy, aromatherapy, and you could probably list a bunch of others. So the primary funder for research into integrative and complementary health is the National Centre for Complementary and Integrative Health as part of the National Institute of Health. So the NIH has 27 centres and institutes, and the NCCIH is one of those. It started 20 years ago, and as complementary and integrative therapies have become more popular, so has the funding availability to do research into not only the effectiveness but also the safety of these. So in the NCCIH, you can see that the budget now is running a little at around $145 million a year, but the NCCIH is not the only centre or institute of the NIH that does this research, and the total budget for the NIH now is running about $370 million a year. Now, one of the other biggest centres that does this type of research is the National Cancer Institute. So these funding agencies obviously provide the funding to do research which is in the clinical arena, often clinical trials, but they also contribute to improving the quality of research. So when we think about research quality, we go back to this pyramid, which is kind of the holy grail when we're talking about research quality. And what it shows us is that the lowest form of research is kind of expert opinions, textbooks, that sort of thing. And then as we move up through a range of the would be the blue, purple, and red, these are what we call observational research studies. And what we mean there is that there's no intervention done to the participants in those research studies. We just simply observe what they do of their own free will. So examples of that would be a case study, an N=1 study, or a case series, a small group of people that all have the same condition. We might do a survey. We might do some sort of longitudinal study, like a Framingham study, where you look at a group of people and their lifestyle habits and the incidence of major healthcare issues over an extended period of time, and you look for what we would call associations or correlations. Now, the reason why that's lower down on the pyramid is because you can't establish a cause and effect relationship. It's a correlation. We think that cigarette smoking might cause lung cancer, but it also could be because people are living in very polluted environments. So at the end of the day, the best thing you can do is talk about associations. So as soon as we moved into a randomized controlled trial, we do have the ability to talk about cause and effect relationships, and it's because of the randomization step. So when we recruit a bunch of people to participate in a clinical trial, of course they're going to come in with all their own little quirks and habits and things they like to do and things they never do. So some people are going to eat a great diet, sleep 8 hours every night, exercise regularly, all things that you would want somebody to do to sustain their health, and other people would be on the other end of the spectrum. So if you randomize all of those, what we call other things that you're not interested in studying, confounding variables, get randomly assorted to the various treatment groups. And so they still influence the outcome, but they don't influence the outcome in one group any more than the other group. So you kind of neutralize the impact of them. And so at the end of the day, if you're comparing the group that got the treatment versus the group that didn't get the treatment, you can say if there's a statistically significant difference and the group that got the treatment did better, you can say with confidence that it was the treatment that caused that better outcome, and therefore the overall conclusion of the study is that that treatment is effective for that particular condition. So you can see they go right towards the top, that red bar, the paler red bar, second from the top. And then at the very top is what we call a systematic review. So this is where a researcher will take a whole bunch of randomized controlled trials that are all looking at the same question, and in many cases pool the data and do a giant statistical analysis, what we call meta-analysis, and draw overall conclusions based on a very large number of participants in a very large data set. And so that's obviously the best. And those are randomized controlled trials. So the systematic reviews are the form of evidence that informs government, insurance agencies, healthcare policy, best practices, etc. So the NIH and all that funding ultimately helps us to create this hierarchy of evidence. And once you get a critical mass at the top, then we can say with confidence that that therapy has demonstrated clinical effectiveness and efficacy. So in the realm of integrative health and medicine, this critical mass of evidence has been developing over the last couple of decades, but even as early as 2009, what I'm showing you here, the National Academy of Medicine in Washington held a summit to look at integrative medicine and the health of the public, the role that this approach to healthcare could take in improving the healthcare of the public. So that was 10 years ago. Also, there was a Senate hearing on the role of integrated care as a pathway to a healthier nation, also in 2009. And fast forward more recently, but has been in process for the last 10 years, is this incorporation into the Veterans Administration of complementary and integrative health. And I'm going to come back to that to talk in a little more detail about that. So how does this form or this approach to healthcare address those issues that we talked about at the beginning of my presentation? Well, it really addresses this issue of prevention and wellness. It puts that at the forefront. In other words, we don't want people to get sick in the first place. And we recognize that health care, taking care of people once they get sick, is not a mechanism for preventing people from getting sick. And interestingly, when we look at it from a cost point of view, 85% of that 20% of our GDP is spent on conditions that are as a result of lifestyle issues. So they're chronic lifestyle-based conditions. So heart disease, diabetes, and many incidences of cancer can be traced back to lifestyle choices. So patient empowerment and responsibility. So it's a partnership. In integrative health and medicine, the practitioner partners with the patient. We try to even the playing field and take away the hierarchical nature. The patient then feels a higher level of motivation and responsibility to want to make those changes. And also we need to take time to explain to patients the relationship between what's happening to them and the things that they're doing and how they can change those things and make a difference to their quality of life and their health. So mind-body. So we're finally moving away from this archaic notion that ill health is related to the physical aspects of our body. And more so now than ever before, and quite tragically, we're acutely aware of the psycho-emotional aspects of illness. And as I mentioned before, most sadly in our youth. We want safer approaches to health problems, and we need to focus on reducing the side effects. We also want to reduce the number of interventions. As I mentioned before, 40% of interventions in this country are unnecessary. So we want to do a lower impact, safer, and looking to see whether we can do a wait and see instead of immediately putting somebody on drugs or suggesting they have surgery. We also need to focus on our practitioners. We have a crisis there too, where healthcare providers, through a combination of factors, are showing burnout at rising levels. So about 60% of doctors that have been surveyed showed signs of burnout. So in part, this is because of the payment system. Even those value-based or capitation models, a lot of the way that healthcare centres get around that is they reduce the amount of time that the doctor has to see an individual patient. So they just put more patients in the system because they're getting paid according to the number of people that they are taking care of. So this is causing physicians, obviously, to not have enough time, but also there's a whole ethical and moral piece to that. They're human beings. They went into this profession because they wanted to help people, and the system is making it harder and harder for them to do that. The other thing is all the technology, the electronic health records, and all the clicks, and the amount of time that they have to spend doing electronic health records instead of actually doing healthcare. And ultimately, if we are committed to prevention and wellness, we're not going to see the benefits cost-wise in the short term, but in the long term, we will see a lowering of costs associated with healthcare. And studies that have been undertaken with integrative health and medicine looking at cost effectiveness have shown that it is more cost effective. But there are some challenges, and we'll talk about those. So if this is the story, we've got these 5 licensed professions, we've got medical doctors doing integrative health and wellness. Why aren't we seeing more of it? What do we need to do in this whole dissemination and implementation arena? Well, let's go back to the evidence pyramid. So generally speaking, intervention is ready to be implemented when we've satisfied a critical mass of research at the top of that pyramid. So we need to have the randomized control trials and we need to do the systematic reviews. But what I didn't mention last time is what comes out of a systematic review is also the clinical practice guidelines. And so when a clinical trial is undertaken and it's successful, we can then go back to the protocol that was used in that clinical trial and say with confidence that that is an effective way to treat that particular condition. So this is what we call clinical practice guidelines. So I want to give you one example for acupuncture. There's been over 7,000 clinical trials undertaken on acupuncture alone. And we can see if we look back to 1991 and compare it as time has progressed. This shows you the number of positive recommendations for pain. That's the dark bars on the lower part. And then the grey shaded bars above is the number of positive recommendations for acupuncture for non-pain conditions. So for those of you that think acupuncture is mainly for pain, just sidebar, it's acupuncture can treat anything the patient comes in with. It's a whole medical system. And we've got a lot of evidence for acupuncture for a whole bunch of different conditions. And interestingly, that kind of peaked out in 2014. And around that time, the NCCIH, I'm actually on the advisory council for the NCCIH, we decided at that point we don't need any more research evidence. What we need now is for people to do implementation science. We need people to figure out, based on the research evidence, how do we get acupuncture, as the example we're looking at, how do we get that into clinics and hospitals? How do we educate other healthcare providers so that they know when to refer, how to co-manage a patient that is also getting acupuncture. So now we're seeing very little funding available for these clinical effectiveness trials, as more funding goes into two areas: firstly, implementation, but more importantly, actually mechanism. The big buzz at the NCCIH now is, well, if acupuncture is so effective, how does it work? Because sticking needles into somebody is obviously fairly challenging in terms of thinking, well, how would that actually work? So there's been some beautiful and sophisticated research that's been undertaken, actually largely at Harvard Medical School, looking at the ability of acupuncture to modulate brain function, looking at the ability of acupuncture to upregulate a whole range of neuropeptides, but especially endorphins, and looking at the anatomical basis of what actually happens mechanically when you put a needle into somebody and how does that then change the whole physiological response. So the take-home message from this is that we are ready to implement, and it's now just a case of looking at the other potential limitations. So what are these ongoing challenges? Well, I mentioned that we do have cost-effectiveness studies. So we do have studies that show that a range of these different integrated therapies reduce the cost. But the problem with cost-effectiveness studies is that it's very specific to the system in which you do the study, because each healthcare system has their own unique way in which they allocate costs. So some might require a department to pay for their own rental costs. Some might have some sort of split arrangement with the healthcare practitioners that work in that department. So they might give them health insurance, but their salary might be dependent on the number of patients they see. So it's very difficult to extrapolate cost effectiveness from one system to another. So we prove it in Kaiser Permanente in California. That doesn't necessarily mean that it's going to work in Hackensack Meridian in New Jersey. Payment. So the payment for these integrated therapies is growing. It's better on the West Coast than it is on the East Coast. New Jersey is better than a lot of other states on the East Coast, but it's still patchy, and it depends on the employer and whether they select coverage for individual therapies like acupuncture, for example. As we move towards value-based reimbursement and bundle payment approaches, we will see more of these incorporated because there will be a payment method. Now, Medicare coverage is really the holy grail of then the private insurers covering these therapies. So Medicare does cover chiropractic. It does not cover acupuncture. But Medicare just announced that they will cover the cost of acupuncture interventions in approved clinical trials for seniors. So part of that $950 million that was allocated by the NIH has gone towards seniors because they're going to become 20% of the population by 2030. And a lot of it is focused on these integrative approaches to health. Of course, we need to educate other healthcare providers. So if we're going to put more integrative healthcare practitioners into a healthcare system, then people need to better understand what each other does in interprofessional education. We also need the other providers to understand that in some cases, the best thing they can do, or following best practice guidelines, is to refer to the integrative healthcare practitioner. So we know now that certain pain conditions have a best methodology. So it might be massage therapy or acupuncture. And we also have a situation because of the opioid crisis where the Joint Commission that accredits hospitals has mandated all healthcare facilities that have that accreditation, which is almost all of them, to provide non-pharmacological interventions as the first line of care for pain. So this is no longer optional. This is an accreditation requirement. So that really ups the ante to solve the two big problems, which is how we're going to pay for it and how we're going to educate the healthcare providers and the administrators within the conventional healthcare settings so that we can do this. So I want to finish with the Veterans Administration. So the Veterans Administration is the largest healthcare system in the world because it consists of a little over 322,000 full-time healthcare professionals and their support staff, and a little over 1,200 standalone healthcare facilities. So about a little under 10 years ago, the Office of Patient-Centered Care and Cultural Transformation was established. And within that, this approach called the whole health model has been developing. And basically the whole health model is where you consider the full range of physical, emotional, mental, social, spiritual, and environmental influences that are going on in a veteran's life. So we're moving away. The VA realizes this is no longer about just find the problem and fix it, the physical approach, but really the focus is now on the individual needs of each veteran. And one of the first steps they've taken in their whole health model is to implement 5 of these complementary and integrated healthcare therapies. Now, they have their own payment system, so they do not have the challenge of who's going to pay for it. They do have the educational challenge, but they don't have the financial challenge. So the therapies they've introduced is yoga, chiropractic, acupuncture, meditation, and Tai Chi. And the picture I put up in the preceding slide was of a veteran doing yoga. So this gives you a diagrammatic version of the whole health model. One of the first questions that a veteran will be asked when he or she comes into healthcare is, what are your important priorities in your life? Like, why do you want your health restored? What is it that's really of value to you in your life? So they identify something that's very personal to them that is this longer term goal for why they want to get well. And so we can see the approach here is very much patient-centered, focused on this individual person, and it looks at all of the various influences, so the social determinants of health, but even kind of beyond that. So it's obviously the physical, it's their surroundings, it's their relationships, it's their own personal sense of spirituality, it's how they recharge themselves, meditation, sleep, obviously nutrition, balancing life and work, and then looking at aspects of their own personal mental health. So down the bottom we see this combination of the individual with their own tailored self-care approach, which the health coach will help them to figure out. And combined with professional care, which would be biomedicine combined with these complementary integrative therapies, and also a focus on providing community and avoiding isolation, which is becoming a growing problem in our modern society. So what we really see here in the VA is a model for the nation. We need to obviously solve the payment system, but I think that what we're going to see from the VA, because this has all been studied in the research model as well, is that this not only lowers healthcare costs, but also can help to rehabilitate even people that have been stressed to the extent of our veterans returning from the battlefield. Now, unfortunately, we're just starting to see now publications coming out about this system. So this one was just published in 2019. And what we're going to see increasingly in the research literature is more and more information about this, which will help for it to be disseminated and become a model for the nation. So that's my talk. So I saw one person had a question.
Could you say a little more about the evidence-based research? I didn't quite understand your PowerPoint slide on acupuncture, because I've heard of acupuncture does have some real evidence-based research on positive outcomes. And one of the things that make me maybe a little suspect is that there's no one particular condition that is good for everything. So when I hear that, I go, well, wait a minute, how can it be good for everything? But that was my question.
Right, so there's sort of two ways I can answer that. So I'll answer the first one, which usually goes down better. We know that it's effective for a whole range of conditions because each individual condition has been separately tested.
Oh, okay.
Yeah, so there's these giant evidence summaries. One came out in Australia a couple of years ago, where they will have a table of a whole bunch of conditions where there's very high quality evidence, which is based on sort of two things: the number of trials that have been undertaken, leading to a systematic review, but also the quality of the methodology associated with the clinical trial. And then there'll be a second table with a bunch of conditions with, what they might call excellent, and then there's good quality, and then poor quality. So we know that it treats a range of things based on evidence. Now I'll give you the other way that I can answer that, and that is, Chinese medicine has been practiced for somewhere between 3,000 and 5,000 years. And in China, it was the healthcare system until very recently, like within the last little over 100 years. So approaches within the discipline of Chinese medicine were developed for anything that people had. Now, I'm not saying that it's effective for anything that people have. There are many cases where biomedicine is the way to go. If you're in a car accident, if you have a heart attack or a stroke, you don't want to go to your local acupuncturist. But, considering that 85% of our healthcare costs are associated with chronic lifestyle-based conditions, those are all either preventable or the symptoms treatable with a healthcare system like Chinese medicine.
Can I have a follow-up question?
Sure, yeah.
So, I don't know what particular condition that they got the top, like a randomized controlled trial on it. But like, for example, say type 2 diabetes or high blood pressure, they would be two conditions that if acupuncture, there was real good evidence, the top two things in your diagram would be fantastic.
Yeah, those two things are not in that top 10.
They're not. Do you know what's in there?
Things like post-operative nausea and vomiting, headaches, back pain, knee osteoarthritis, neck pain, those sorts of things. But in the next table, which is good evidence, there'd be things like high blood pressure. And, type 2 diabetes is that's a complex one because that is, there's a whole constellation of symptoms that go into that. So it might be peripheral neuropathy. It could be about additional blood sugar control above the medications that they're already taking. So, you know, integrative is about also combining. So particularly in cancer care, you know, acupuncture is obviously not going to be used as the main treatment for cancer, but it's very good for chemotherapy-induced nausea, depression, anxiety, all very common symptoms that somebody going through a cancer treatment is experiencing. And, you know, so let's just take peripheral neuropathy as an example. I mean, what else is there that's good to treat that? Kind of nothing. But if you come into a Chinese medicine practitioner, it's not even acupuncture, it's actually moxibustion, and it actually can help to bring back a lot of sensation into those lower limbs. So in some instances, it's where there really is not a good approach. It's like those people either just suffer with the condition, or if they're fortunate enough to know that they can seek out a different approach like acupuncture, then they're actually going to get some relief.
So with the integrated model that you described that the VA is using, like that sounds so wonderful. I was just wondering with, you know, specifically the opiate crisis, how do you foresee kind of the cultural or mindset shift happening? Because I know a lot of patients come in wanting a quick fix, and that's kind of expected. And specifically with, you mentioned the reimbursement being like quality, however you describe the quality reimbursement, you know.
Value.
The value reimbursement. So, you know, for the doctors, I know it can be very frustrating when they're trying to either maybe, I know that now there's laws and things too to wean the opiates or suggest or refer for other things, but then when they get pushback or negative rating from the patient satisfaction scores, you know, that's very frustrating, especially when that's connected now to the physician's reimbursement and payment. So it seems like you would need to get the patient on board with this for both parties to be satisfied. How do you foresee that kind of like changing, I guess?
Yeah, I mean, you know, definitely the integrative approach. So, yeah, it's not okay for somebody to be told you can't have the medication, you just have to suffer in pain, go to the acupuncture and I hope it gets better, because acupuncture is not going to help them immediately like the drugs will. So you can start them off on the drugs, they do the acupuncture will gradually be more effective over time, so it has a cumulative effect, and then you can wean them back off the drugs. But when they're talking about pain is a very complex condition, and there's, you know, as you guys know better than I do, there's a big psycho-emotional component to it. So that part has to be addressed too. Now, can the acupuncturist help with that? Maybe. It depends a lot on the patient-practitioner interaction. But also, I think, you know, this growing movement of group medical visits, which can be used with acupuncture, to group acupuncture, where you develop a support network with the other people that are in the group. You start to find out a little more about the social determinants. That is another good component. But I think you have to, for pain, go at the whole thing from multiple angles. So some drugs, some integrative therapies, maybe some talk therapy, cognitive behavioral therapy. Yeah.
The traditionally trained person, how much of a time do they get like an hour? They're so underpacked. How are they buying into having all this digital medicine in their hospitals?
Yeah, no, it's very hard. I mean, I've been on the faculty at Albert Einstein College of Medicine for 10 years, and it's a whole cultural thing. It's very hard to change the curriculum. It was very hard to change curriculum, period. But in medical school, because it's so intensive, and there's just an overwhelming amount of new stuff that they constantly have to consider putting into the curriculum. But there are new innovative approaches. So Hackensack Meridian has just started medical school, and they're doing very much sort of a community-based approach. So students right in their first year are actually going out and becoming a attached to a particular family and then they follow that family over an extended period of time. So it's really focusing on these social determinants of health. And I think that helps to just break up the old paradigm or way of thinking, and I think people then naturally become more open to different approaches like integrative health. But we have been doing a lot of outreach activities. I used to work in a Chinese medicine school, and so we would visit this was in New York City, so we would go to NYU, Einstein, Columbia, Cornell, and regularly give talks. And the young medical students are really open to it. They want change. They don't see these things as odd, and they also don't see them as competitive. So, you know, I have a lot of faith and hope in the youth. They're, I think, our future, and I think that's how things are going to change.
Are you involved with AMSA?
With who, sorry?
American Reading Association?
A little bit. So I read quite a bit of their content, but I'm not actively involved.
Good organization, they take no work from it.
Yeah, that's cool.
I'm probably oversimplifying this, but you showed a chart at the very beginning that was talking about how this all increased like around 2010. And I just didn't know if there was anything any factors that have been really determined that caused such a great increase.
Sorry, increasing.
There was opioid epidemic.
Oh.
When
Yeah, well, it was this pain is the fifth vital sign. So when pain was classified as the fifth vital sign, in other words, that meant that you always had to ask about pain. So there was a lot more disclosure about, oh yeah, no, I had this, bad hip pain or this bad back pain. And then so you have to do something about it. And so then there was a lot more prescribing. And then, kind of took off from there. But that was the catalyst, was pain is the fifth vital sign.
I'm just wondering if there's any talk about the energetic body, which is a huge part of acupuncture, yoga, meditation, Reiki. It's all about the chi, right? It's the life force that's moving through us. And so that's why we're saying that it can feel all these different parts of the body. It's because of it's the energy. It's not really the physical. So I'm wondering, is there dialogue about the energy body, or is it kind of shoved to the side right now because it's not evidence-based and it doesn't fit in a Western model?
Yeah, yes, that is all, everything you just said towards the end is the reason. And so when you become an acupuncturist, you have to do almost 4 years of study. And it's a master's, and the profession has transitioned to an entry-level doctoral degree now. So it's an enormous amount of study, and it's very hard. And a lot of it is learning Chinese medicine theory, which has all of those concepts in it. It's a beautiful and elegant medical system. However, when you try and talk to people about that, and in simplistic terms, it just sounds very hokey, and it's very non-scientific. So a lot of people like myself compartmentalize and do not talk about that in certain professional settings. But amongst my peers, that's everything we talk about. We talk about patients. And it's also a model for how you can think about everything, society.
Yeah, but I think it needs to be talked about. Otherwise, we're not really progressing and growing. We're just pretending like that part of it doesn't exist.
Yeah, no, I absolutely speaking to the converted. But I think that we have to do it very strategically. So once we get people a little more on board, then you can introduce a little more of these concepts. Many years ago, over 10 years ago, I read a paper that was kind of life-changing for me in terms of how we think about this issue. Interestingly, the lead author was a guy called Ben Cleveland, who is now head of Integrative Medicine and Veterans Administration. He's a medical doctor and a very successful researcher. But basically, the paper was about how we need to change the curriculum in medical schools to incorporate knowledge about integrative therapies. But what he said at the end was, we don't really need to teach people about all these individual therapies and, what acupuncture treats and all these details. We need to share with them the philosophy of the medicine. And I think that really will have a profound impact on healthcare. But it's a process. People can only hear things when they're ready. So we are still in that phase of getting people ready. And, in Chinese, crisis is 2 characters, and the second character is opportunity. So as we move into this crisis, it's providing opportunities. Like, people are really taking notice of these different approaches now because we've got this terrible crisis on our hands for 130 people dying every day, and it's getting worse, not better. So the more things we try to do in the drug arena, it's not helping. So people are now suddenly, yes, we're open to trying a different approach. So once you can sort of demonstrate this is helping somebody, then you can slowly start to talk about the other stuff, because their heart is open and receptive, and all that judgment and everything has gone into the background. Okay, well, thank you very much, and enjoy the rest of the day.
Thank you. And now we have the PTSD. Thank you.